It's great to see you, and I really appreciate that you came out on a Sunday morning to hear some exciting news about treating food allergies. I've been working with Dr. Rendawa's nonprofit, TPERC, for about a year now, after he helped both of my children overcome their allergies to peanut, milk, and 8 tree nuts. Thanks to Dr. Rendawa, my 2 kids have eaten pad thai, peanut butter and jelly sandwiches, and ice cream. They've been to Dodger games. They've enjoyed sleepovers, and they've flown to see their grandparents by themselves. Tomorrow, I'm dropping my son off at sleepaway camp. Thanks to Dr. Rendawa, my kids get to be normal kids, and I get to be a normal mom. In a couple minutes, you'll hear Dr. Rendawa speak about how he treats every food allergic kid as an individual with a protocol that's designed specifically for that child. You'll learn why his precision medicine-based approach to oral immunotherapy is the best, and why his patients are the safest food allergic kids around. After spending a decade in the trenches as a food allergy mom, desperate for my kids' safety, a sometimes obsessive student of OIT, clinical trials, and the doctors and institutions who are treating food allergies, and a proud mother of 2 OIT pioneers who've worked and fought for their freedom to be normal kids for more than 3 years, I'm convinced that Dr. Rendawa is the answer to the food allergy epidemic. After we hear from Dr. Rendawa, I'll say a few words about how our food allergy community can and must begin to transform the lives of the millions of children living with food allergies. That'll give Dr. Rendawa a chance to review the questions that many of you submitted. Thank you for doing that. We will have a brief question and answer at the end of the morning. I'm going to ask and remind you to please refrain from asking specific questions about your child. This really isn't a suitable forum for that. He doesn't have information about your child on hand. He also has limited time this morning and has other obligations at the hospital, so we want to try and get as many questions answered as we can. Before Dr. Rendawa, we're going to play you a short video, so sit back and relax. After that, Greg Lichtenstein, who's around here somewhere, is going to get up and talk to you about why he chose to have Dr. Rendawa treat his son and why he's such a tremendously valuable supporter of Dr. Rendawa and his nonprofit. Thank you.
We brought Layla home just a few days after she was born, March 20th, 2011, and it was about a
on. Can you hear me okay? Is there a mic here? Hi, I'm... There's no mic. A mic? Okay, well, I'll do what I tell my kids to do, speak up. I'm Greg Lichtenstein, and I have 2 kids. My son, Hayden, is 10, and he's food allergic. My daughter's 13, and no allergies so far. And my wife and I heard about Dr. Randhawa recently. Very fortunate for that. We learned that our son had food allergies when he was about a year old. He had a tiny bite of scrambled eggs, and his eyes swelled shut. He was covered in hives. He was screaming. We took him to the doctor, rushed him there. They did tests, and we found out that in addition to being allergic to have life-threatening allergy to eggs, he was also anaphylactic to all nuts as well as mustard seed. And so we live in Los Angeles, and we have access to top doctors. We're very fortunate to have access to the top doctors in LA. And we spoke with our pediatrician, all the allergists and immunologists that we could talk to. And across the board, the consensus was avoidance. So when you hear this as a parent, you think, okay, well, that's what we're supposed to do. We have to give our child as normal of a life as we can give him. And then, which was not easy. Several years later, we heard about a food challenge program at one of the medical centers, the big ones out here in Los Angeles, and we decided to, against the wishes of our pediatrician, to give it a try. And it was difficult to convince our then 4.5-year-old son to eat the very things that he thought would kill him. So it was a huge trust thing between us, my wife and I, my wife and me, and him. And we convinced him to do it because his parents told him he'd be okay. Well, he wasn't okay. He was put into anaphylaxis deliberately. He was vomiting profusely. He was in extreme discomfort, and it was nothing short of barbaric. And so when we realized that that was sort of the way the doctors at that point were conducting these food challenges, had we known what those outcomes could have been, we probably wouldn't have done it. But what happened was that our son lost faith and trust in me and my wife. He lost faith and trust in the doctors who were caring for him. And as a parent, you have a moral dilemma. You have the fear of, am I going to let my child go through life with his life in danger, with not knowing what he can eat or what he cannot eat? Or you also can have the fear of, if this doesn't work, will he no longer trust me and people who can take care of him? And so how do you reconcile that as a parent? We decided it wasn't worth the risk, and so we just continued avoiding those foods. We heard about a second food allergy program in another medical center in LA, and my son now, at that point, he was 7, and he said there was no chance that he would do it. Had we heard about Dr. Randhawa at that point, we would not have been fortunate to become a patient because there was such a lack of trust there. And so that second food allergy food challenge program, the doctor then wanted to do the blood work and just start challenging him, but to go slower than last time. And so my son again was just filled with terror, and he wouldn't do it, and we opted just to say, you know what, enough is enough. We've accepted avoidance, and we're just going to hope to give him as normal a life as possible. And then we heard about Randhawa. Not from a pediatrician, but through some friends. And so when we asked around, people had heard about him. There wasn't a lot of awareness yet. We called the office and found out that there was an 8-month wait at that time, and we figured, okay, something's going on in Long Beach. So what do we have to lose? We put our name down on the wait list, and then 8 months later we got a call from Herman. Thank you for that call, Herman. And when we drove down to Long Beach, we didn't really know what to expect. We were very educated as lay people, and when we had that 90-minute meeting with Dr. Randhawa, who was as patient as possible and empathetic and sensitive and understanding, it really felt like we were talking to someone who was really understanding of what we were going through. It was the first time in almost 10 years that we experienced that, and we had that trust with him. So I'll let him talk about the science and the treatment and why precision medicine is how he can solve all these problems. But I will tell you this, that one of the most renowned allergists in the city 10 years ago told me and my wife that our son would never be able to touch, be around, much less eat or consume an egg for the rest of his life because of it was anaphylactic and life-threatening. I will tell you this, after 4 months in treatment with Dr. Ndawa, I have breakfast with my son every morning and I cook him scrambled eggs. And I can tell you, thank you. And I can tell you that I'm not great at cooking scrambled eggs, but it's the best tasting scrambled eggs that I've ever tasted. So we're past soy. We're now on to chickpeas. We're going to see him a couple weeks for that. We're going to be on to pine nuts and peanuts later. And I can just tell you that it is nothing short of miraculous. And as a result of, and by the way, it's he can have eggs, and not only has he had In-N-Out burger with a special sauce, but he puts more mayonnaise on his hamburgers than it's probably healthy. So that's something we're also dealing with. Like, buddy, ease up on the mayo. Like, I know you want to brag to your friends, you can put it on it, but that's okay. As a result of this, I wanted to help spread awareness because when I've taken some video clips of my son passing egg and soy and having his maintenance food at home, and we've sent video clips to some of our friends who have food allergic children. And the amount of emails that we get from our friends and family who say, well, how can we get in touch with this doctor? It's heartbreaking to tell them that you have to wait. At the time when we started, I think it was a 2-year wait, and now it's closer to 3 years. And so my wife and I thought, what can we do to pay this forward, to give back, to help other kids who may not know about Rendawa, who may not be 30 minutes from Long Beach. So we are in the process of producing a documentary film about him, about children who are going through this, about the families who are going through this with them, families whose children have graduated, just so that people can be aware that these are real outcomes and these are real families. Beyond this, if there's, in closing, I just want to mention one thing. If there's one takeaway from my story, when we began treatment with our son, we were so focused on the potential outcomes of treatment. Will he be able to live a normal life? Will he be able to go to sleepovers and go to camp and not pick his fingernails off of his fingers because he's so terrified of what's going to happen to him? Like, will he have those outcomes? More important than those outcomes, I will say, is the trust that he creates with your child. To Dr. Rendawa, it's obviously important to help restore childhood for your children, but it's equally important to him that he connects on a deeper personal level with each of your children, because if your child experiences the terror and the trauma and the fear of this, it's not going to work, because it's not a vaccine. It's not come to the hospital and he sticks you with something and then you're done, go have an egg. It is a sometimes months-long, over a year-long period where it involves families, grandparents, siblings, parents of the kid's friends. It is a commitment. And so that relationship that he develops and cultivates with each of you and your children is just as important as the outcome he's trying to create. And to know that my son jumps in the car to go see Dr. Rendawa, to feel empowered that he can beat an allergy is to me more important than the fact that he's no longer food allergic to some of these foods. So it's seeing my child become empowered, to become confident, and to become a normal kid again, and having that trust in us and his caregivers is something that I can't thank him enough for. And so I hope all of you get the opportunity to experience the same thing that I have.
All right. Good morning. So I'm Dr. Rendawa, in case you can't tell by that video. No, I want to thank Katie and Greg and a few of our other food allergy graduates who decided to come to this this seminar, this little bit of education in this process. And I'd like to thank you all for coming out. I mean, it is a Sunday. I have to work on this Sunday anyhow, rounding in the hospital, but you are here because you are most invested in the top priority of your life, your child. And what I hope to do today, in 30 minutes, 40 minutes or so, is to hopefully answer most of your major questions in regards to what this process is. There is no good Google search that'll answer all your questions, unfortunately, at least yet. But it is something that's important. You need to feel before you ever sign up for anything that you have put all the options out on the table, that you have a good understanding of what this is, because this is not just for you, this is for your child. And children see this very differently than, than the parents. I always tell parents one thing when their child starts treatment. Whatever you do, don't say this. Cashews are amazing. They're delicious. You're going to love them. Because I'm telling you, kids who've never eaten a nut in their entire life don't know what it tastes like. So it's like telling somebody this movie is hilarious, you're going to love this movie, and then you just totally get let down. So the point is, it's all perspective, right? So children come from a very different perspective when they've gone years without eating a food of a certain texture and so forth. So again, I'm hoping we can answer your questions for you today. And then, by the time you leave here, you feel enabled to make what is the best decision for your child. So I'm going to answer in a handful of slides just these questions. And the first question is, why should I even consider oral immunotherapy, or what we call OIT, for your child? Why do this? Why is this considered a necessary thing? There are 20 million people approximately in this country with food allergic disease, food allergic anaphylaxis. 20 million. It's not a rare disease, right? It is very common. If that's the case, how many people are actually doing oral immunotherapy? Even amongst conservative estimates, meaning you just put in more people that are there, you may have 3,000 people actually doing this in this country, and probably worldwide, of which 1,000 plus are here. So, why such a discrepancy? 20 million to 3,000. So hopefully we can explain some of that for you. Why should I be worried about OIT? You talk to folks, you talk to your pediatrician, you talk to your family practice doctor, you talk to your own allergist in your community, and you're going to hear all kinds of information. And what information is valid, what information is questionable. These are brief things I'd like to discuss. Does OIT even work in general? And I'll briefly go over that, and the answer to that is, yes in many ways, and potentially unsure in some other ways. Why is it not more widely offered, right? I mean, if this is such an amazing thing, Greg used the term miraculous. I don't like to use those kinds of religious terms because, this is science. This is very, very good science. But nonetheless, it is there, and why is it not more widely offered? We'll talk about that. What are my options to receive OIT? Where can I go? There's a long wait list here. What else can I do? What are my options? And I'll give you my perspective on that. What is my story with this whole OIT thing? I think usually once parents are in this process for a number of months, if I haven't already told you, you kind of get why I'm doing this. But for those who have not had that opportunity, I often like to explain why I do this and what drives me to see this through to the finish. What are the greatest threats to long-term success of OIT? This is kind of an odd question, but it's actually a very, very important question. Having therapies that start and don't last are very questionable therapies. Therapies that you start for 2 or 3 years and suddenly they disappear, those are therapies that should be of concern. So there are legitimate concerns about how long this type of therapy may be available to children as a whole, and that's something that we have to pay attention to. Second to last, why is developing a sustainable model of oral immunotherapy really important for your child? Why do you need a model that sticks around? You need a model that ensures 5 years, 10 years, 20 years from now that your child, who will be an adult at that time, has a place to go to know where their immune system is towards this allergic condition. And lastly, why you should consider supporting this precision medicine form of treatment, and we'll obviously get to that. So again, why consider OIT? It's not a numbers game, right? You guys obviously aren't concerned about the actual economic hit that takes place in this country every year, because of food allergies. In every classroom, if you have 30 kids in a classroom, typically two of them or 3 of them are going to have a food allergy, a food allergic anaphylactic allergy, which is what we're talking about specifically here. And these allergies are going up. We're seeing a rise in this over the last decade. That's certainly been published in recent literature. And similarly, this accounts for an incredible number of visits to the emergency room and other outpatient settings. So these reactions happen all the time. I'm on intensive care unit rounds this weekend, and just yesterday we had a patient in the ICU with an allergic reaction to peanut. So and that's in the intensive care unit, right? So this is something that is going on a regular basis, and the current standard of care is very clear, as Greg mentioned. Just avoid it, right? It's easy, right? It shouldn't be too hard. Just avoid the foods. And carry an EpiPen and hope for the best. That's pretty much the standard of care for the last 100 years in food allergy. Why you want to consider OIT is because what it does to those who are impacted by this condition. This includes families, this includes siblings, this includes the children themselves. This includes the communities that are involved in this condition. Accidental exposures are frequent. It hovers around 1/3. Literally, 1 out of 3 kids who who have food allergies are going to experience an annual event. And this is with people who are actually paying very close attention as to avoiding things, being careful, being extra careful sometimes. And unfortunately, we do not even today, although our center is actually hopefully going to be first to publish this by November, is trying to find out who gets the more severe reactions, right? But to date, we don't know. Your child can have a skin test to milk that's barely positive, and they can have a severe reaction. And you can have a skin test that's, the size of an orange, and they can have relatively mild reactions. Why is that? These are things that need to be studied and understood, but nonetheless, it leaves a significant question mark, because now we're labeling a person with a diagnosis and saying, you are all at risk for life-threatening anaphylaxis. This is why this is a difficult situation. Significant reactions can result in fatalities. The numbers are all over the place, but if you look at most of the data, it's somewhere between 5 to 8 fatalities per month that are attributed to food-based allergic disease. Often those are respiratory deaths, meaning the patients present to the ER in a situation where their airway went down and it was unclear if they ate something, but the history was present. In addition to this, in addition to the worst case scenario, it is the day-to-day impact that hits these kids. And I'll say that I never understood this well until I got into this field over a decade ago. There are plenty of studies that have compared food allergic children to other children with chronic disease, type 1 diabetes, Crohn's disease, and the quality of life of kids with food allergic disease is worse than that of kids who have type 1 diabetes. I mean, that is literally the impact in numbers that is there. We do the best we can. You're doing the best you can as parents to make sure that they live a, quote, normal life. But it is very difficult because food, shelter, water, basic human needs. Number one is food. And everything we do socially and otherwise is circled around food. That's what makes this so difficult, and that's why most parents consider OIT. In addition, the anxiety. Right? The anxiety, I can feel the anxiety in the room, right? It is always there, and it has, again, another set of impacts. There's some very early studies that are showing impact on school performance, especially as these kids get older with food allergies. Socialization, kind of the whole psychosocial development aspects, when children are not allowed to have those normal interactions with their siblings even, or with their friends, it can have that type of impact. Extreme parental supervision, and I emphasize extreme. This is something that's a necessity. This is not being a helicopter parent for grades, right? This is life. This is serious. And that is something that tends to change that dynamic between parent and child, and it can be very, very difficult. When I first started doing this, again, a decade ago plus, the vast majority of patients who came to me were actually homeschooled. And they were not homeschooled because they elected to be homeschooled. They were homeschooled because they were having reactions at, most of them, nut-free schools, right? So again, there's just so much difficulty in trying to control that environment that plays a role. So many people would describe a limited family existence, unable to kind of have those vacations, trips with other folks, et cetera. Those are very basic things, but they do play a role. And social media involvement. I mean, I don't need to say any more with that. right? Facebook followers. So, so this is one of those things that being in social media, it can often create a cycle of events where that often can either help or actually drive some degree of anxiety. And lastly, failed treatment efforts. I cannot tell you how many various, unusual, strange forms of therapy have been attempted by my patients. Things that include, acupuncture, reasonable but unclear, to iridology. They measure your iris, they give you roots. I've had patients go to other countries. And unfortunately, as Greg had alluded to, it is those failed treatment efforts that make these children not trust anyone, especially during these types of processes. Lastly, you want to think about OIT because of all the stipulations and restrictions that occur at the place where your kids will spend more time than being at home, which is at school. And of course, there's the nut-free tables. Those are there. The stigma that's associated with that. I was talking to Greg yesterday about a young lady who finished peanuts many months ago. Very stoic, very quiet, unlike a lot of the other kids where they become very expressive over time. And it took her eating 22 peanuts and then about to leave the clinic, and she said, I told her, well, hey, you don't have to sit at that table anymore. And then she broke down. Then it finally hit her that stigma where she actually had to sit at this nut-free table alone for many years, knew that could be lifted. Recess, outdoor exposures, cross-contamination, we all know about those. 504 plans. Remember, 504 plans are very helpful and valid, but they themselves actually do not focus purely on safety. They're just kind of planned and organizational aspects. Other parents in the school environment often have a poor perception. We know this. You guys have all had to deal with this. You try and convince other parents who are not in the food allergy world, and they tend to downplay your concerns. Food allergy parents who declare the airborne antigen often are overcalling that. And then that creates, a bit of a dichotomy and a bit of mixed messaging. And then, of course, anaphylaxis plans themselves. They are heterogeneous. They're all over the place. Which ones work, which ones don't work. And, of course, if you ever had to actually use an anaphylaxis plan, so many school nurses are not even present on campus in most of our public school system. These are all reasons to think about pursuing OIT. So you hear the positives. So what about the other side, right? Why not do this? And what I tell folks is there's a general issue with this whole OIT thing, and it kind of runs this series of steps. Number one, the academics, and I'm an academic, but the vast majority of academics will argue that it's not ready for general use. And in some sense, I agree with that statement. I think this needs to be done in a very organized, appropriate, safe fashion. So we make those statements, but then we run very few trials. The access point is very, very limited. So we know it's there, we know it kind of works, we don't think it's ready for general use, but we don't actually run enough trials or give enough access to show that it can actually turn into a long-term valid therapy. You have a handful of private practice allergists who are offering this OIT, and there's no consensus on how that is being done. It's done one way at one place, one way at another place, and when you have that type of discrepancy, it becomes a degree of risk. The FDA will not approve these types of individualized treatments. I've said that so many times. Anything that's considered patient-specific, and that doesn't matter which form of OIT you pursue, they are all, to some degree, patient-specific because you're not giving everybody the same pill the entire time. The FDA will not approve that. In addition, the FDA does not like to approve anything that involves food-based therapeutics. They don't do nutraceuticals, they don't do any of those things. And the patch and pill, which are currently in phase 3 trials, we're hosting one of those trials here, the treatment is possible. It's interesting. It provides a degree of protection. But how long is it going to take to get done? It still seems like it's going to take many, many years to get there. And finally, major food allergy organizations that are out there actually do not support OIT. And that's certainly been placed on their websites. So you hear all these negatives. And what this leads to is a lot of confusion amongst the community of patients who are out there. And that's confusion despite our ability to demonstrate we have a large degree of success. So this is a conflict of messaging, but those points have to be addressed. Why also not pursue OIT? Well, the major governing boards, the American Academy of Allergy, Asthma, and Immunology, and the college as well, certainly say right now it is avoidance, that's it. What do they offer as part of their guidelines? Well, they give you kind of allergy cookbooks. They teach you how to read labels. They give you parental or patient support groups. They often tend to engage registered dietitians. I think many of you have been down this road. Certain environmental safeguards, wearing a bracelet, a medical alert bracelet, etc. They offer annual retesting, and they give you this hope that your child may outgrow the allergy, even though you know the chance of that happening is not terribly high. And then, of course, they give you an anaphylaxis plan. So you hear the positives, you know all the potential negatives, at least that are discussed out there in the conversation. And then the question is, does it work? Obviously, I could give you a weeks-long lecture on why OIT actually works. I'm not going to do that. It's very scientifically dense. But this little graphic actually summarizes what OIT does to your immune system. And don't worry about what all of it says, but just look at the time frame. Hours, weeks, months, 6 months, and years. And look at all these branches of the immune system and look how erratic it is, right? I mean, it's kind of confusing. But what we do know is that within various forms of OIT, within a handful of months to a year, you can definitely get patients to eat things. But what does it look like 4 years down the road? What does it look like 5 or 10 years down the road? And can we actually take many of these immune system markers that we like to study and actually prove over time that your child is actually changed? There has to be a burden put on that. We cannot just guess. We cannot just say, well, Johnny looks like he can eat 3 or 4 peanuts, therefore he should be able to eat whatever he wants. Are you sure about that? You know, what if he ate 30 peanuts or 60 or 90 or 100 peanuts? What would happen? There are ways to study this more appropriately. So the answer to the question is, we do know it works in the short term. We do know that over time, a lot of these parameters do change, but this is something that actually needs to be done, again, safely, effectively, and you have to follow those long-term outcomes. Why is OIT not offered more widely, like I mentioned earlier, right? And fundamentally, it comes down to a couple different things. Number one, if you look at all the major studies that have been done, on average, you have around a 5% epinephrine use, EpiPen use during treatment. And to be honest with you, some of the ones are higher than that, some are slightly lower, but that means 1 out of 20 kids who go through this is getting Epi at least once during the treatment. And that's something that's disconcerting to anybody else who's thinking about doing this. They say, well, that doesn't sound good. And then the risk, the risk of reaction, the risk of injury, and the risk of fatality. All too often we talk about the worst case scenario in food allergy. We don't talk about the patients who end up in the ICU and the patients who actually can suffer significant injury from having an allergic reaction. So because of that risk, and in 2006 there was a fatality historically in a trial that actually halted a lot of what we were trying to do back then. It did not occur here. It was done through an external organization. Those types of things they play loudly in the minds of individuals who are thinking about doing this. And with oral forms of immunotherapy, OIT, pill therapy, etc., these systemic reactions are common. You're looking at kids who are getting exposed to the food during treatment, and they're getting hives and wheezing and swelling of the lips and so forth. And again, as Greg mentioned, those are things you can't really do during therapy. If it happens, it should be infrequent or rare, and that's something that we try to do aggressively. We try to maintain that in our center. Last 2 things. The GI symptoms are intense in most of the reported literature. Pretty high number of GI symptoms, meaning these children are eating their doses during the week and they're having stomach pain, they're vomiting, they're having symptoms that put them at risk not only for not continuing that therapy, but also at risk for other types of conditions like EOE. So that's a lot of risk. If you're going to a new doctor and saying, hey, listen, check this out, right? I mean, they're probably going to say, well, I don't know about this. This sounds a little difficult. And then you add to that cost. Now, Greg mentioned, our initial intake visit was 90 minutes long. We don't get paid for 90 minutes, And so this is something that takes and invests a lot of time. It's a time-consuming process. It is not easy to do this with the degree of efficiency necessary, and as I'll explain to you how we've been able to develop this center, we've been able to offset a lot of this cost, but the risk and the cost